So maybe we can invite all the panelists to come on. And we have, as I see, 5 minutes now available for discussion. So Dr. Srinivas, do you have any questions in the chat? I can't really see any questions.
This platform, actually, we are streaming them. That is the challenge with these platforms. I think we can discuss amongst ourselves, and then if something comes in WhatsApp, we'll see.
Okay. Perfect. Perfect. So Dr. Vikram Lele, is he on?
Yeah, he joined, madam. You can ask him to talk a few words. His panelist is waiting since long.
Oh,
yes, sir.
Hi.
Thank you.
Yes, I'm here.
Hi, Vikram. Thank you so much for joining. So I know that you are kind of both on the ASNIC side and on the side from Mumbai in India. So what are your key takeaway points from this session, or any points you wanted to make?
Yeah, it's been a great session. I enjoyed listening to all the viewpoints. Now, we have been practicing nuclear cardiology for the last 30 years here. And some takeaway points I got from this is that we now have to provide the flow reserve measurements to the cardiologists. It's an extremely powerful indicator of coronary disease. And PET technology is the well-established, robust technology which gives us the flow reserve. And it's about time that we get PET routinely into cardiology practice. In India, we have 2 centers where PET is being done. One is at the All India Institute and at the PGI Chandigarh, where they have a cyclotron, they can do ammonia, but somehow it has not being utilized. It's being utilized as a sort of a glorified thallium. We are not using the flow reserve values, which are so important. And there's so much data now, especially from Professor Lance Gould, that the CFR is in fact a better measure as compared to the FFR. The FFR is basically a pressure measurement, while the CFR is a flow measurement. And the FFR is heavily impacted by the global CFR. So if you have a global CFR value, it will be of more importance than an isolated segmental FFR value, which has several limitations. So I think it's time that we got this very powerful parameter into practice, and it is our hope to get rubidium into India at some point. Before that, if flupyridase comes into the picture, we would embrace it gladly. But till it comes, I think a well-performed and well-interpreted myocardial perfusion scan with all the parameters, not only perfusion, with the ejection fraction, transient ischemic dilatation, all considered, is still an extremely powerful method. And if it is normal, after a good level of exercise, you can avoid unnecessary coronary interventions, even though your angiography shows significant coronary artery disease.
Yeah, thank you so much. I agree. So I don't know if any of the other panelists have questions, but one question I had was calcium score. Is it being utilized in conjunction with perfusion imaging? Because that's a very simple measure, and CT scanners are all over. So Johan, go ahead.
Yes, Dr. Nirmala, we have a small experience. In fact, we did it with one of our radiology fellows, where patients who did not have a prior coronary angiogram or a coronary anatomy visualized, we did the nuclear scans, and whenever there was a problem, small attenuation defect or a perfusion which was very mild, no LV dysfunction, we went ahead and did a calcium scoring for all of them. And what we did find was, at least in our lab, and this was just about 100 cases, not more, that the number which was the threshold for us was 192. Above that number, these patients had a significant ischemia. And below that number, the ischemia was mild and they were managed medically. These patients were followed up for about 6 months only. And the ones with a lower calcium score, similar perfusions, were managed medically, did well. This is, of course, only 6 months data. And the went ahead and were revascularized. So very short, small data, which we then sort of embraced. And we took it up as any patient who came without a prior coronary anatomy for a nuclear scan, we would do a calcium score to reassure the referral person that when we are giving you normal perfusion, a low calcium score is also supportive. But there are fallacies, but this is our small experience.
All right, Dr. Servus has a question. Go ahead, please.
Yeah, I think that calcium score is certainly important, but what we have seen, at least in Europe and mainly in London, is the combination of calcium score of multi-slide CT scan visualizing score, the calcium, and then combined with PET. And Mark Dweck has really investigated that field and is using the term hot calcium and cold calcium. And I think that's something which is very important because we always consider that the calcium was a marker of the disease. It's the end result probably of necrotic core becoming calcified. But obviously, he has clearly demonstrated by longitudinal study that there is hot calcium, which is dangerous, and there are cold calcium, quite stable, which are not dangerous. That's maybe the only additional notion that I would like to add to the debate today, because I don't think it was specifically mentioned.
Yeah, excellent. Thank you so much. So the one point I wanted to really highlight, the one other point was Dr. Viviani Taketi's talk. She really touched upon the microvascular dysfunction in great detail, and it's an important and emerging area, I think, particularly for countries like India, where there's so much diabetes. The prevalence of diabetes is so high. And I do agree with Dr. Srinivas about treatments, but clearly, I think identification of the problem is the first step. So Viviani, are you aware of any treatments for microvascular dysfunction being evaluated currently?
Thanks so
In
much.
the medical treatment, I think there are some drugs like trimetazine which are being proposed, but I'm not sure of any intervention. Sorry, over to you, man.
Right. I just wanted to ask her because she's really leading the research in this area.
Yeah, it's a great question. So, I think PET, as I think has been emphasized by so many of the speakers today, is such a versatile tool, and the strengths really lie in its ability to quantify blood flow and be used as a complementary functional assessment with anatomic assessments, including CTs, which are done routinely for attenuation correction, right? So as mentioned, calcium scoring. And so it is such a versatile tool, especially for such a heterogeneous patient populations that we are seeing more and more in our clinics, and are certainly reflective of the Indian patient population. Shamila, as you mentioned, who has a very, they have a, like Americans, but perhaps even more so, have a very high rate of metabolic disorders and with potential implications for future coronary events. And some of this manifests in the classic way of a big heart attack, like a ST elevation MI, for which we have really great therapies, right, which are primarily interventional. But a lot of that has to do with good medical management. And so we don't have enough data yet, but there's a lot of interest, as you heard from, again, many of our speakers and debaters today, about what exactly will be specifically targeted for microvascular dysfunction. I think we are still at the stage where we're trying to define disease, because right now it's really a heterogeneous mix of pathophysiologic phenotypes, right, which reflect different endotypes. And as Dr. Sura has really pointed out very elegantly, is probably a combination of the atherosclerotic burden along the entire kind of epicardial vessel, which we can now quantify using invasive or non-invasive coronary CTA with high sensitivity, as well as more distal functional disease, which we can also increasingly evaluate both using sophisticated non-invasive tools like PET, and as Dr. Thompson pointed out, even potentially SPECT in the future. But also there's a lot of interest from the interventional community who is developing more sophisticated and precise tools that are catheter-based, as you also have heard about diagnosing specifically microvascular resistance and the index of microcirculatory resistance. And I think all of this is such good news for our patients and also our community, because the real evidence-based treatments will start with precise and standard diagnostics. And that's really where we're at right now. So I'm very hopeful for the future. I think there are a lot of interesting trials, including with novel agents like PCSK9 inhibitors, as well as a lot of the diabetic new agents like SGLT2 inhibitors, GLP-1 agonists, which may have a real role to play in this disease, which again affects a lot of different people, including the vast majority of our patients who have hypertension, diabetes, metabolic syndrome, obesity, and chronic kidney disease, as well as, are somewhere along that spectrum of atherosclerotic disease burden.
Yeah, no, very nicely summarized. It's really a fascinating area, particularly extending it into heart failure. I think the burden of heart failure is so vast globally. I think this is your work and work from others really highlighted to us the importance of this pathophysiology in causing both heart failure as well as ischemic heart disease.
Yeah, I think it's interesting because I used to say that NOCA, non-obstructive coronary artery disease, is almost a misnomer. There is clearly two components. You have the plaque burden, which can create problem at any time, but you don't have microcirculation problem, and vice versa. You can have only microvasculature problem. And that's all put together in NOCA. So we have really make an effort to make the distinction between both, and also to educate the people about the physician about there is two entity there which has one common name, and that's always dangerous in medicine when you give one common name to two physiopathology. And I think that the NOCA, which is really a heavy plaque burden, non-encroaching the lumen, not impacting on the epicardial conductance, there is some hope there, because I think that with these powerful therapy on LDL cholesterol and now on inflammatory aspect, the last MAB reduced the CRP by 97% at the highest dose. I think there is some hope for these people. I'm a little bit less optimistic for, the diabetic, which has destroys capillary system or have very thick wall in the microcirculation. I don't think we are very close to a good therapy for these people, and we have really to make the difference. But for the first group, I think that what COVID has done for all of us is to show the power of the microRNA component, and to have 2 shots per year of inclisiran, for instance, which is a microRNA, is really something which is going to create secondary prevention and primary prevention of quality. In Oxford, Novartis is really considering trial with kids between 12 and 18, where clearly the phenotype of the disease will appear because the genomic is so bad. And there is a nice term for that, is imagomics. It has been created by Jean Baldwin after a few glasses of wine, but that's a wonderful term, yeah.
And I think those are great
much.
Dr. Ball, I'll just add something that Dr. Bork always highlights, and I think is such an important point. Exercise may have a real role to play in these patients as well, and is available to everyone, and is certainly underutilized. So I think, along with all of these targeted, innovative therapies, I think so important for us to highlight the potential for, essentially good functional capacity exercise in this patient population.
Absolutely.
Thank you, Sharmila. I think Patrick Seres is getting delayed. I think we can conclude. Yeah.
Okay, perfect. So maybe I will ask Dr. Randy Thompson to give a concluding remark on how nuclear cardiology and SPECT could be combined for the evaluation of patients.
A nuclear cardiology and SPECT, or CT and SPECT?
SPECT, everything together.
Well, as we've been talking about, our fields are becoming more quantitative and more oriented toward flow. And probably you will not need a PET scan or a detailed catheterization approach to diagnose microvascular disease in the future. The SPECT blood flow is close, and I think that'll be a major advance and allow us to diagnose the kind of patients that we're talking about worldwide, those with microvascular disease or non-obstructive disease with atherosclerotic burdens, for example. What I said in the talk that I'd just highlight is that when you add an anatomical assessment to the physiologic assessment, something as simple as a modern SPECT myocardial perfusion imaging study and a visual estimate of the coronary calcium from a CT scan, maybe one that was done in the hospital or one that's done as a attenuation map. It's a very powerful tool, takes our imaging to another level in predicting which patients will benefit most from the interventions that you all do in interventional cardiology.
Perfect. Thank you so much. So really amazing session. Thanks to all the speakers, Dr. Servus, Dr. Reiber, Dr. Jamison Burke, Johan Christopher, Viviani Taketi, Dr. Vikram Lele, Randall Thompson, and who else? Sorry, I'm just looking at my second page here.
All this
So
became
thank you
possible
all.
because,
Really amazing.
Sharmila, all this became possible because of you. Okay.
Thank you,
Absolutely.
Thanks.
Absolutely. Thank you all. We'll continue the collaboration for next year as well. Thank you all.